Here is a medical magic trick that experienced rheumatologists seem to perform before you even sit down. They hold your hands, turn them over, press a few joints, study your nails, and within seconds they already have a strong idea about what may be happening. You may not have finished describing your symptoms. Yet your hands have already given away part of the story. It sounds like guesswork. It is actually pattern recognition built from years of seeing the same clues repeat in different combinations. Lupus, Sjogren's disease, and rheumatoid arthritis can all make the hands ache, swell, stiffen, burn, tingle, change color, or stop cooperating with ordinary tasks. At first glance, they can look almost identical. A patient may simply say, "My fingers hurt every morning," and that sentence could point in several directions. But underneath that overlap, each disease tends to leave a different signature. Today, we are stealing the rheumatologist's playbook and becoming hand detectives. 3 suspects. 3 different patterns. 1 pair of hands carrying more information than most people realize. By the end, you will know why the exact joints involved matter, why a clean X-ray can be misleading, why a finger that turns white in the grocery store freezer aisle deserves attention, and why burning fingertips can be a nerve problem even when every standard nerve test comes back normal. If you keep leaving appointments remembering symptoms you forgot to mention, I made a Sjogren symptom map to help you track the full pattern. Comment "symptom map," and I'll send it to you. One warning before we begin. This is not a test you can use to diagnose yourself. Autoimmune diseases overlap, early disease can be subtle, and common problems such as osteoarthritis, carpal tunnel syndrome, medication effects, thyroid disease, diabetes, and simple overuse can imitate parts of these patterns. The purpose is not to hand you a label. It is to help you notice the details your doctor needs to hear. And the first detail is not simply, "Do your hands hurt?" The better question is, where exactly do they hurt, when do they hurt, and what can you see or feel when they do? Look at one hand for a moment. The large knuckles where the fingers meet the hand are called the metacarpophalangeal joints, or MCP joints. The middle finger joints are the proximal interphalangeal joints, or PIP joints. The joints closest to the fingernails are the distal interphalangeal joints, or DIP joints. Then there is the thumb base and the wrist. To most people, these are all just knuckles. To a rheumatologist, they are different addresses, and certain diseases prefer certain addresses. Let us begin with the joints because all 3 of today's suspects can show up there. This is the clue that creates the most confusion, but it can also become the most useful once you understand the pattern. Rheumatoid arthritis, or RA, is the most structurally aggressive member of this lineup. It commonly causes inflammatory pain and swelling in the wrists, MCP joints, and PIP joints, often on both sides of the body. The DIP joints near the nails are usually spared. That distribution matters. If the joints closest to your fingernails are the main painful, bony, enlarged joints, especially along with the thumb base, ordinary osteoarthritis may be more likely than classic RA. If the large knuckles and middle joints are soft, puffy, tender, and stiff on both hands, RA moves higher on the list. The swelling in active RA often feels different from a hard bone bump. It may feel soft, springy, or almost spongy because the lining of the joint, called the synovium, is inflamed. A ring that fit last month may suddenly refuse to pass over a knuckle. A patient may notice that the valleys between the knuckles have disappeared because the whole area looks puffy. Making a fist becomes difficult, not only because it hurts, but because the swollen tissue physically limits the movement. Then there is the morning pattern. Many people with RA describe waking with hands that feel locked, thick, or covered by an invisible pair of tight gloves. The stiffness often lasts well beyond the first few minutes of the day. It may improve gradually with movement, a warm shower, or simply time. That is different from the short-lived stiffness of some mechanical joint problems, although no stopwatch can diagnose arthritis. More than an hour is a useful clue, not a law. Here is the detail that gives RA its reputation. Persistent, uncontrolled inflammation can damage cartilage and erode bone. Over time, that damage can change the architecture of the joints. Fingers may drift toward the little finger side of the hand, a pattern called ulnar deviation. A finger may develop a swan neck shape, with one joint bending backward and the joint near the fingertip bending down. Another may develop a boutonniere pattern, with the middle joint bending down while the fingertip points upward. Tendons can also become inflamed, weakened, or even rupture. But do not make the common mistake of thinking that every person with RA will develop these deformities. Modern treatment can dramatically reduce that risk, especially when disease-modifying treatment begins early. The severe hands shown in old medical textbooks often reflect years of inflammation that was untreated or treated before today's options were available. The point is not that deformity is inevitable. The point is that RA has the ability to cause permanent structural damage, which is why delays matter. There is another correction almost every patient needs to hear. An early hand X-ray can be normal even when RA is active. Plain X-rays are good at showing established bone damage, but they are not perfect at catching the earliest inflammation. Ultrasound or MRI can sometimes detect synovitis, tendon inflammation, or early erosive changes before a standard X-ray does. So a clean X-ray does not mean nothing is wrong. It means this X-ray did not show established damage today. Now lupus enters the room and makes the picture much more deceptive. Joint pain is extremely common in systemic lupus erythematosus. Lupus arthritis can be inflammatory, symmetrical, and concentrated in the small joints of the hands and wrists. It can cause stiffness, tenderness, and visible swelling. On the surface, it may look enough like RA to confuse patients and even clinicians who do not see autoimmune disease every day. The classic difference is that lupus arthritis is usually non-erosive. In other words, it generally does not chew into bone in the same way that classic RA can. But usually matters here. Medicine is full of exceptions, overlap syndromes, and patients who refuse to follow the textbook. A small group of people with lupus can develop erosive arthritis, sometimes called rupus when features of both RA and lupus occur together. That is why the hand pattern is evidence, not a verdict. Lupus can create a particularly strange deforming pattern called Jacquard's arthropathy. Instead of bone erosion being the main driver, repeated inflammation and looseness in the tendons, ligaments, and other soft tissues can allow the fingers to drift or bend. The hand may resemble advanced RA at first glance. The difference is that the deformities may be reducible, especially earlier in the process. A clinician can gently guide a finger closer to its normal position because the bones have not been destroyed in the same classic pattern. That creates one of the great plot twists in rheumatology. A patient's fingers may rest in an obvious ulnar drift, yet the hand looks much straighter when positioned for an X-ray. The image may show surprisingly little bone damage compared with the visible deformity. The X-ray is not lying. It is answering a narrow question about bone while the main problem is living in the soft tissue around it. Reducible does not mean painless, harmless, or easy to live with. Soft tissue laxity can weaken grip, reduce pinch strength, make buttons difficult, and turn writing, cooking, or holding a phone into exhausting work. Some deformities can also become less reducible over time. A person does not need eroded bone to have real disability. If you have ever been told that a normal X-ray proves your hand symptoms are not serious, type normal in the comments. That belief has delayed answers for too many people. Then we come to Sjogren's disease. Most people hear Sjogren's and think only of dry eyes and dry mouth. That narrow picture misses how often the disease affects joints, nerves, blood vessels, muscles, lungs, and other organs. Joint pain may affect a substantial share of patients, and studies report a wide range because the groups studied and definitions used are different. Some people have arthralgia, which means joint pain without clear inflammatory swelling. Others develop true inflammatory arthritis. The usual Sjogren's joint pattern is milder and non-erosive, often involving the hands, wrists, knees, or ankles. It can resemble RA in distribution, especially when the small joints of the hands are involved. The patient may wake stiff, struggle to form a fist, and notice swelling that comes and goes. Yet the X-rays may not show the progressive erosions expected in uncontrolled classic RA. However, saying Sjogren's is never erosive would be inaccurate. Erosive changes can occur, and the possibility becomes more important when anti-CCP antibodies are present, when synovitis is persistent, or when a patient may have an overlap with RA. Sjogren's can exist on its own, but it can also occur alongside rheumatoid arthritis or lupus. In that situation, asking which single disease owns every symptom may be the wrong question. Here is a home observation that can help without turning you into your own doctor. On a bad morning, take clear photographs of both hands from the same angle. Photograph the palms, the backs of the hands, and any color change. Note how long the stiffness lasts, which joints are swollen, whether a warm shower helps, and whether you can make a full fist. By the time of an appointment, swelling or Raynaud's may have vanished. A time-stamped photo can show what your memory struggles to describe. Now we move from the joints to the skin, because the outside of the hand can reveal a completely different category of clues. Lupus has the widest and most dramatic skin vocabulary of these three diseases. The famous butterfly rash across the cheeks gets most of the attention, but lupus-related skin changes can appear on the hands too. Red or reddish-purple patches can affect the fingers and the spaces between the knuckles. Some lupus eruptions on the back of the hands tend to spare the skin directly over the knuckles. That location creates a useful contrast with dermatomyositis, a separate autoimmune disease that can cause muscle weakness and a classic rash over the knuckles. Sjogren's papules are raised, red to purple bumps that sit directly on top of the finger joints. In simplified terms, a rash over the knuckles raises concern for dermatomyositis, while some lupus hand rashes favor the areas between them. But this is a clue, not a do-it-yourself diagnostic rule. Eczema, psoriasis, contact irritation, cold injury, medication reactions, and many other conditions can affect the same small area of skin. A rash must be judged by its color, texture, duration, sun sensitivity, symptoms, distribution elsewhere on the body, and sometimes a dermatologist's examination or biopsy. Cold weather introduces another lupus clue called chilblain lupus. This can produce tender red, purple, or dusky areas on fingers and toes after cold exposure. The lesions may last longer than an ordinary Raynaud's episode and can feel sore, itchy, or burning. Because the color is similar, people sometimes confuse chilblain lesions with Raynaud's. The timing helps separate them. Raynaud's usually comes in attacks with color changes that improve as circulation returns. Chilblain-type lesions can remain visible for days or longer. RA can also cause nail fold or vascular changes, and severe long-standing disease can rarely cause rheumatoid vasculitis. This is important because the original easy comparison, RA only affects joints while lupus and Sjogren's affect vessels, is too neat to be true. RA is a systemic autoimmune disease. It can affect the lungs, heart, eyes, nerves, skin, and blood vessels. The hand pattern may begin at the joints, but the disease is not trapped there. Sjogren's skin changes can be quieter. Dryness may cause rough, cracked skin that becomes more obvious around the fingers, especially with frequent washing or cold weather. Some patients develop purpura, small red or purple spots caused by bleeding under the skin, more often on the legs but potentially elsewhere. Vasculitic rashes may be raised, tender, persistent, or accompanied by other systemic symptoms. A spot that does not fade when pressed is different from simple surface redness, but appearance alone still cannot tell you the cause. If a new rash appears with fever, severe weakness, rapidly increasing pain, darkening skin, open sores, or signs of infection, that is not a watch it for 6 months situation. It needs prompt medical evaluation. Now we reach one of the most revealing hand clues in Sjogren's and lupus: what happens to the fingers in the cold? Raynaud's phenomenon is an exaggerated narrowing of blood vessels in response to cold or emotional stress. A finger may turn pale or white as blood flow drops. It may become blue or purple as oxygen falls. Then it may turn red, throb, burn, or swell as circulation returns. Not every attack displays all three colors, and the colors can be harder to recognize on darker skin. Some people mainly notice numbness, a clear border between affected and unaffected skin, or a painful warming phase. Raynaud's can be primary, meaning it occurs without another known disease, or secondary, meaning it is connected to an autoimmune or vascular condition. Primary Raynaud's is common and often less dangerous. Secondary Raynaud's deserves closer attention because the underlying blood vessels may be injured or inflamed, not merely overreactive. Sjogren's is one possible cause of secondary Raynaud's. Older research found it in about 1/3 of some Sjogren's groups, while newer cohorts have reported lower rates. That variation is exactly why a single percentage should not be treated like a universal promise. The key fact is that Raynaud's can appear before the classic dryness symptoms and, in some patients, before the Sjogren's diagnosis itself. Lupus can also cause Raynaud's. So can systemic sclerosis, mixed connective tissue disease, inflammatory muscle diseases, certain medications, smoking, vibration exposure, and other conditions. That is why Raynaud's is an alarm bell, not a name tag. It tells the clinician to ask more questions. A rheumatologist may examine the tiny vessels at the base of the fingernails using magnification, a test called nail fold capillaroscopy. Abnormal loops, bleeding, enlarged vessels, or loss of vessels can support concern for a secondary connective tissue disease. The test does not diagnose lupus, Sjogren's, or RA by itself, but it adds another piece to the board. Now let us separate Raynaud's from vasculitis, because people often use the words as though they mean the same thing. Raynaud's is primarily a problem of vessel spasm. Vasculitis means inflammation that damages the blood vessel wall. Both can reduce blood flow, but the mechanism and level of concern are different. Vasculitis can produce persistent red or purple spots, tender bumps, ulcers, areas of dead-looking skin, or severe pain that does not behave like a brief cold-triggered episode. Lupus and Sjogren's can both cause vasculitis. RA can as well, although rheumatoid vasculitis is now less common and usually associated with severe, long-standing disease. A few red dots on a fingertip do not automatically equal vasculitis. Trauma, infection, tiny clots, bleeding problems, and other diseases can look similar. If cold makes your fingers change color and you have never shown your doctor a photograph, type photo in the comments. That may be the most practical step in this entire video. The next clue is invisible. Your fingers may look completely normal, yet they burn as if they touched a hot stove. They may sting, buzz, tingle, feel painfully cold, or go numb without any obvious swelling. This is where nerves enter the detective story. Sjogren's can affect the peripheral nervous system in several ways. One of the most frustrating is small fiber neuropathy. Small nerve fibers carry pain, temperature, and some automatic body signals. When they malfunction, a patient may describe burning feet or hands, electric pinpricks, painful sensitivity to light touch, strange hot and cold sensations, or pain that seems far greater than anything visible on the skin. Here is the diagnostic curveball. Standard nerve conduction studies and EMG mainly assess larger nerve fibers and muscle responses. Pure small fiber neuropathy can leave those tests normal. A normal result can therefore mean, the large fibers tested normally, not, every nerve in your body is healthy. When symptoms strongly suggest small fiber neuropathy, clinicians may consider a skin punch biopsy to measure intraepidermal nerve fiber density or use specialized tests of temperature sensation and autonomic function. Even then, no single test explains every burning sensation. Diabetes, prediabetes, vitamin deficiencies, thyroid problems, infections, alcohol, certain medicines, chemotherapy, and other immune conditions must also be considered. Lupus can also cause peripheral neuropathy. Inflammation, blood vessel injury, antibodies, medication effects, and unrelated conditions may all contribute. Eye can compress or injure nerves too. Swelling in the wrist can crowd the carpal tunnel and press on the median nerve, causing numbness or tingling in the thumb, index, middle, and part of the ring finger. Symptoms may wake a person at night or appear while driving, holding a phone, or gripping a steering wheel. Weakness deserves special attention. Pain can make a hand feel weak because the brain avoids a painful grip. True nerve or muscle weakness is different. A person may drop objects without warning, lose the ability to turn a key, struggle to lift the fingers, or notice visible muscle wasting. Sudden weakness, especially with facial drooping, speech difficulty, severe headache, or weakness on one side of the body, is an emergency. Do not assume every neurological symptom comes from a known autoimmune diagnosis. The next detective tool is the laboratory, and this is where many people expect a single test to deliver a final answer. Unfortunately, autoimmune blood work is less like a guilty or not guilty verdict and more like witness testimony. Some witnesses are highly specific. Others are common, noisy, and easy to misunderstand. Rheumatoid factor can support an RA diagnosis, but it is not exclusive to RA. It can appear in Sjogren's, other infections, or illnesses, and even in some healthy people. Anti-CCP antibodies are more specific for RA and can help identify patients at greater risk for erosive disease, but a negative anti-CCP test does not eliminate RA. Seronegative RA exists. ANA, the antinuclear antibody test, is positive in most people with lupus, but it is not a lupus-only test. It can appear in Sjogren's, other autoimmune conditions, and healthy individuals. A positive ANA without a matching clinical picture is not a diagnosis. More specific antibodies, complement levels, blood counts, kidney tests, urine testing, and the patient's actual symptoms help determine whether lupus is likely and whether organs are involved. Anti-SSA, also called Rho, and anti-SSB, also called La, can support Sjogren's, but not every Sjogren's patient has both, and anti-SSA can appear in lupus as well. Some patients need objective dryness testing, salivary gland evaluation, or a lip biopsy when the diagnosis remains unclear. A negative antibody panel does not erase symptoms, but it does mean the clinician has to build the case from other evidence. Inflammation markers such as ESR and CRP can add context, yet they can be normal during real autoimmune symptoms or elevated for reasons that have nothing to do with autoimmunity. Blood tests should be interpreted together, not read as separate online quizzes. Now let us clear up the most dangerous myths one by one. Myth number 1. A normal X-ray rules out rheumatoid arthritis. It does not. Early RA can inflame joints and tendons before plain radiographs show erosion. Clinical examination, ultrasound, MRI, laboratory evidence, and time can reveal what the first image misses. Myth number 2. Sjogren's only causes dryness. False. Sjogren's can affect joints, nerves, blood vessels, lungs, kidneys, and other systems. Dryness may dominate one person's disease and barely explain another person's most disabling symptoms. Myth number 3. Every cold hand is Raynaud's. No. Cold hands are common. Raynaud's usually produces attacks with a visible or clearly felt change in blood flow, often with distinct color borders, numbness, pain, or a throbbing recovery phase. Persistent discoloration needs evaluation for other circulation problems. Myth number 4. Every case of Raynaud's is harmless. Primary Raynaud's often remains manageable, but secondary Raynaud's can cause ulcers or tissue injury. Adult onset, severe pain, asymmetry, abnormal nail fold vessels, fingertip sores, or other autoimmune symptoms raise the level of concern. Myth number 5. A normal nerve conduction test means the burning is psychological. False. Pure small fiber neuropathy can produce severe symptoms while routine studies remain normal. The result must be matched to the type of nerve fiber the test was designed to examine. Myth number 6. If my antibodies are negative, I cannot have autoimmune disease. Also false. Negative tests can lower the probability of certain diagnoses, but seronegative disease exists, and not every antibody is present in every patient. The opposite is also true. A positive antibody without matching symptoms does not automatically prove disease. Myth number 7. Once I have one autoimmune diagnosis, every new hand symptom belongs to it. This is one of the most costly assumptions. A person with lupus can still develop carpal tunnel syndrome. A person with Sjogren's can still have osteoarthritis. A person with RA can still get gout, an infection, or a pinched nerve. A known diagnosis should guide thinking, not end it. Now for the rapid-fire questions people usually ask after seeing these patterns. My X-ray is normal, but the ultrasound shows inflammation. Which one is right? They may both be right. The X-ray may show no established bone damage, while ultrasound detects active soft tissue inflammation. The tests see different things. I have dry eyes, dry mouth, and hand pain. Does that automatically mean Sjogren's? No. Dryness can result from age, medications, dehydration, sleep problems, hormonal changes, diabetes, eye conditions, and other causes. Sjogren's becomes more likely when the full clinical picture and objective testing support it. Can I have both Sjogren's and RA? Yes. Sjogren's can occur as a primary disease or alongside another systemic autoimmune condition. A person with established RA may also develop significant dryness and other Sjogren's features. Overlap is one reason neat internet comparisons sometimes fail in real clinics. Can lupus and RA overlap? Yes. Some patients have features of both, sometimes described as rupus. Because erosive hand disease is not the classic lupus pattern, clear erosions in a patient labeled with lupus deserve a closer look rather than an automatic assumption. Does tingling mean small fiber neuropathy? Not automatically. Carpal tunnel syndrome, ulnar nerve compression, neck problems, diabetes, vitamin B12 deficiency, thyroid disease, medication effects, and many other problems can cause tingling. The exact distribution and testing guide the next step. Can small fiber neuropathy start before dryness? Neurological symptoms can precede a Sjogren's diagnosis, and some patients reach neurology before rheumatology. That does not mean every unexplained burning sensation is early Sjogren's, but it means the connection should not be dismissed when other clues are present. What if my Raynaud started years before anything else? Tell your clinician. Raynauds can remain primary, but it can also predate a connective tissue diagnosis. The pattern over time, physical examination, nail fold findings, and laboratory testing help decide whether monitoring is appropriate. What if my rings are tight but no joint looks clearly swollen? Photograph both hands and note whether swelling changes during the day. Diffuse puffiness can come from many causes, including fluid retention and medication effects. The location and timing are essential. Can treatment reverse hand deformity? It depends on the mechanism and stage. Active inflammation can often be controlled. Splints, occupational therapy, hand therapy, and protection of joints can improve function. Established bone destruction is difficult to reverse, while some soft tissue deformities may remain partly correctable. Surgery is considered for selected severe problems, not as a universal answer. Should I exercise painful hands? Gentle, individualized motion and strengthening can help many people, but forcing an acutely inflamed joint or copying a generic routine can make symptoms worse. A rheumatologist, occupational therapist, or certified hand therapist can match exercises and splints to the actual problem. This leads to the part viewers can use immediately: how to prepare for an appointment so the most important clues do not disappear inside the sentence, "My hands hurt." First, make a joint map. Print a simple picture of both hands or draw one. Circle the exact joints that hurt. Mark swelling with a different color. Note whether the wrist, thumb base, large knuckles, middle joints, or fingertip joints are involved. A rough map is more useful than a perfect paragraph. Second, track time. Record how many minutes pass before your hands move normally in the morning. Note whether activity helps, worsens, or does both depending on the task. Write down whether symptoms wake you at night. Third, photograph visible events. Capture swelling, rashes, fingertip spots, nail fold redness, and Raynaud's color changes. Use natural light when possible and include both hands for comparison. Do not use filters. Note what triggered the event and how long it lasted. Fourth, describe function. Doctors need to know what the symptoms stop you from doing. Can you button a shirt, turn a key, open a medicine bottle, type, cook, hold a mug, use scissors, or carry a grocery bag? Function turns an abstract pain score into a clear measure of impact. Fifth, list the whole body clues. Dry eyes, dry mouth, mouth ulcers, rashes after sun exposure, fevers, unusual fatigue, chest pain with breathing, shortness of breath, numbness, weakness, color changes, swollen glands, dental problems, and changes in urine may connect the hands to a systemic pattern. Do not assume the specialist only wants to hear about joints. Sixth, bring a complete medication and supplement list. Some medicines can worsen dryness or trigger Raynaud's-like symptoms. Supplements can affect bleeding, kidneys, or interactions. It is natural, does not mean it is irrelevant. Seventh, explain family and personal history without treating genetics like destiny. Autoimmune disease in relatives can matter, but it does not prove your diagnosis. Previous blood clots, miscarriages, infections, smoking, vibration exposure, chemotherapy, and other medical conditions may also be relevant. What should you avoid? Do not stop prescribed medicine just to make swelling visible at the appointment. Do not plunge your hands into ice water to provoke Raynaud's. Do not force a joint straight. Do not diagnose a rash from one social media photograph. And do not let a single normal test end the conversation when the clinical pattern is persistent and changing. Here is a simple script you can take into the room. For 4 months, the large knuckles and middle joints of both hands have been swollen. Morning stiffness lasts about 70 minutes. Heat helps. I cannot make a full fist when I wake up. The fingertip joints are mostly fine. My first X-ray was normal, but here are photographs from 3 bad mornings. I also have dry eyes and episodes where 2 fingers turn white in the cold. That description gives a clinician far more to work with than, "Everything hurts." Now let us return to our 3 suspects for the final comparison. Rheumatoid arthritis most strongly points toward persistent inflammatory swelling in the wrists, MCP joints, and PIP joints, often symmetrically, with long morning stiffness and the potential for erosions, tendon damage, and fixed deformity if inflammation is not controlled. The fingertip joints are usually spared. Early X-rays can still be normal. Lupus often causes symmetrical hand and wrist pain, stiffness, and swelling without the classic erosive pattern. Jacquard's arthropathy can create deformities through soft tissue laxity, making the hand look damaged while bone imaging appears surprisingly mild. Lupus can also add rashes, nail fold changes, Raynaud's, chilblain-type lesions, vasculitis, or neuropathy. Sjogren's commonly brings joint pain and sometimes inflammatory arthritis that is usually non-erosive. It may add dryness, Raynaud's, burning, or tingling from neuropathy, and vascular or skin clues. Because Sjogren's can overlap with RA or lupus, persistent synovitis, erosions, or anti-CCP antibodies deserve a closer look rather than being waved away as just Sjogren's. And the diseases outside today's lineup matter too. Osteoarthritis favors hard bony changes at the fingertip joints and thumb base. Psoriatic arthritis can involve the fingertip joints, nail pitting, and whole finger swelling. Dermatomyositis can place a purple-red rash directly over the knuckles and cause true muscle weakness. Systemic sclerosis can combine Raynaud's with puffy fingers, skin tightening, fingertip pits, or ulcers. Carpal tunnel syndrome follows a nerve distribution and often worsens at night. Infection can make one area rapidly red, hot, swollen, and dangerous. That is why your hands are not a diagnosis. They are a map. Before we close, remember the 4 situations that should move you from routine note-taking to prompt medical care. 1. A finger stays pale, blue, very dark, or intensely painful and does not recover. 2. You develop an open fingertip sore, blackening tissue, or rapidly spreading redness. 3. A joint becomes suddenly hot, red, severely painful, especially with fever. 4. Numbness or weakness appears suddenly, spreads quickly, or comes with facial droop, speech trouble, chest pain, or breathing difficulty. Everything else still deserves attention when it persists, but those red flags should not wait for the next convenient appointment. Here is what I want you to remember when this video ends. Your hands can reveal where inflammation prefers to live, whether the main problem may involve bone, soft tissue, blood vessels, skin, or nerves, and which questions need to be asked next. RA, lupus, and Sjogren's can all produce the sentence, "My hands hurt," but they do not always write that sentence in the same handwriting. RA often writes through swollen small joints, prolonged stiffness, and a risk of structural damage. Lupus can imitate the joint pattern while leaving less classic erosion and adding soft tissue deformity, rashes, or vascular clues. Sjogren's may combine joint pain with dryness, Raynaud's, and invisible nerve symptoms that a standard test can miss. The goal is not to stare at your fingers until you frighten yourself. The goal is to replace vague worry with useful observation. Which joints? Both hands or one? Soft swelling or hard bone? Minutes of stiffness or hours? A passing color change or a persistent sore? Numbness in 3 fingers or burning everywhere? A normal X-ray or a complete normal evaluation? Those details change the conversation. If this helped you recognize a pattern you could never explain before, type hands in the comments and share the video with someone who keeps being told that all autoimmune hand pain looks the same. It does not. And if you want the next piece of this investigation, watch our breakdown of the 20 body parts autoimmune disease can quietly affect. The hands may be where the clues become visible, but they are rarely the only place the story is unfolding. Watch your hands. They are talking. The answer is not always obvious, but the language can be learned. I will see you in the next one.